Hi guys, this is Dr. Jake Pace.
And I'm Dr. Samir Mall.
This is the first screencast that you're going to encounter in preparation for your Airway Day in the next couple of weeks. The first thing we wanted to cover was the overall approach to our airway algorithm when thinking about managing a patient's airway.
So what this slide essentially goes through is the entire airway algorithm. And don't be overwhelmed by this, as different elements of this algorithm are talked about in other lectures that are further along in our pre-course material. But the decision to intubate can be potentially complex, and what we want to do is try to break it down into some simple umbrella categories that Jake and I think about, so that you have a safe algorithm to fall back on when you have a difficult patient in front of you.
Yeah, just to elaborate on what Samir said, when you look at the airway algorithm that's sent out to you in your emails, it looks a little bit bigger than that. That's because we've taken the foreign body algorithm out of this. The reason we did so, there's an entire separate screencast that's dedicated to the management of a foreign body. Just to make things a little less cluttered, we've removed that. The other things to look for, there is another screencast on the awake airway and also the salvage airway and RSI. We'll go over that stuff briefly during this screencast.
And again, this screencast is not to go through specific airway techniques and drugs necessarily, but just to talk about big decision making and how you can make the safest airway choice for your patient. So starting off at the very top, you're going to start with your clinical assessment of the patient, right? So if they have a foreign body, you're going to go down your foreign body algorithm, which we cover somewhere else. The next two big categories that Jake and I think about, firstly, number one has to do with respiratory failure and whether or not there's a failure for the patient to ventilate or oxygenate, right? So we need gas exchange for basic organ function, and we want to avoid hypoxia. If the patient in front of you, due to whatever disease process that they have, whether it be asthma, COPD, bad pneumonia, sepsis, if they're unable to oxygenate sufficiently with supplemental oxygen via face mask, you're going to proceed to some sort of trial of non-invasive ventilation. Also under this category, we talk about kind of a work of breathing and energy supply and demand for these same patients who are really working hard to breathe, to get gas exchange. That takes an immense amount of energy from their bodies, and if eventually these patients will tire out. So these are also patients who we can potentially support with a non-invasive ventilation trial.
You know, when you try your non-invasive ventilation, there's something else you are working on to try to correct the patient's underlying physiology that's driving their respiratory failure or work of breathing. This is not a long-term therapy for patients. This is a bridge to try to reverse whatever process is causing their distressed state. If you are successful in reversing whatever the issue was that was causing the respiratory failure or the work of breathing, you're going to wean that non-invasive ventilation and continue to monitor the patient's respiratory status.
Right, if they're really acidotic and you're able to fix the underlying cause of acidosis with a trial of NIV and other therapy, great. If you're able to relieve extra edema off of the lung from a CHF while you're bridging with NIV, great. You can just wean the patient off and monitor them and see how they respond to your therapy. If, however, that fails, now we're talking about a decision to intubate.
The other way you get to the decision to intubate from this clinical scenario is if someone has a contraindication to non-invasive ventilation. You look at any textbook, there's a handful of contraindications to non-invasive mechanical ventilation, the common ones being altered level of consciousness, severe hemodynamic instability, or peri-arrest situations where non-invasive ventilation would be contraindicated. If someone is nauseated, vomiting, or has gastrointestinal bleeding, those would be other contraindications that would preclude you from using a trial of non-invasive ventilation. So if the non-invasive ventilation has failed, or that's contraindicated, and the patient is in respiratory failure and their inability to oxygenate or ventilate, or a severe work of breathing that's leading to an energy supply-demand mismatch, you're going to be moving towards a decision to intubate. The second silo really comes down to a patient's ability to protect their airway, which allows gas exchange. Some scenarios where you may find that this is a occurring is someone who has an altered level of consciousness, if someone has an anticipated loss of airway, such as an upper airway burn or angioedema, or you have a patient who's combative, who's going to require either advanced imaging or procedures that's going to require sedation to the point where there's a threat to the loss of airway, you're now finding yourself in this second silo which may lead to the decision to intubate. The first thing to think about is there something reversible here? Is this patient opioid toxic? Is a trial of Narcan warranted? Check the patient's serum glucose. Are they hypoglycemic, which is leading to severe altered level of consciousness? If at the end of the day the answer to those questions are no, your decision to intubate has been made, as you must protect the patient's airway to prevent aspiration or further loss or compromise of the airway.
So once you've made the decision to intubate, you've entered one of these two silos, either a respiratory failure, work of breathing issue, or someone who is going to lose their airway. The next big question you have to ask yourself is this a difficult airway or not down here? If you're predicting that this is not a difficult airway using your usual external predictors, we can proceed with an RSI and just have our backups ready like we normally would. And if we're successful, we proceed to post-intubation management. If you think this is going to be a difficult airway, now you have to take a moment and contemplate with your team the best plan. So what are my next immediate backups if laryngoscopy fails? Well, I'm going to try supraglottic, or I'm going to try BVM, or I'm going to try a crike. Again, if you think you can rescue yourself after a failed laryngoscopy attempt, again, you'll proceed straight to an RSI because we're comfortable that we can get ourselves out of a sticky situation. We successfully intubate the patient and proceed to post-intubation management. It becomes more difficult when someone has an externally difficult airway and you think you may not be able to rescue yourself appropriately with a supraglottic airway, a BVM, or potentially a cricothyrotomy. And now in this case, this is the patient who you want to avoid paralysis and do an awake intubation. There will be a whole other screencast on the specifics of performing a safe awake intubation. I won't go through that there, but again, just for the decision making, does this person have a difficult airway? If so, do I think I can rescue myself? If I can, I'm going to go through with a normal RSI. But if they have a difficult airway and I think I have a high likelihood of failure with my rescue devices, I'm going to proceed to an awake. All of this is contingent on the fact that if your patient is really in a bad way and has severe facial trauma or deformities, has no mouth opening, and you don't have any time, that's the patient you're just going to go straight to a cricothyrotomy.
We're hoping that by going over this and verbally walking you through this algorithm, it takes what looks like an intimidating and complex algorithm and breaks it down into what all of us will gain with some element of experience when managing airways, is that there are stepwise algorithmic thought processes that go into whether or not to manage a patient's airway. We will go over the awake airway management strategies in another screencast. We're going to talk extensively about RSI and what it means to be in a salvage airway mode, which is essentially the situation you find yourself in after you fail your first attempt. We think about this again in three big silos: respiratory failure or an energy supply demand issue, silo number one. Silo number two is an airway loss of airway scenario, that's silo number two, and silo number three is an airway foreign body.
Although algorithms can be difficult to follow, ultimately we hope with experience this does become a little bit of muscle memory for all of you. But ultimately, even in the most experienced airway practitioners, these are the very basic thought processes that we all go through when deciding the safest way to manage someone's airway. Once again, please bring all of your questions and difficult cases for discussion at our airway course. We'll be looking forward to answering and discussing difficult cases with everybody. For now, leading up to the airway course, take a moment and try to picture some patients who you think may meet some of these different indications or umbrella categories of airway management, and hopefully this algorithm does make a good amount of sense.
Thank you guys for your attention, and we look forward to seeing you in a couple weeks.